that the SARS-CoV-2 virus infects the cells by binding to the ACE2 receptors together with this protein on the cell surface area. ACE2 receptors are typically found in the lung, some in the heart, in the kidneys, and small intestines. And it's thought that the virus can directly be cytotoxic. This virus may also have an effect on regulation of the renin-aldosterone and angiotensin system by interrupting the breakdown of these active agents, leading to inactive agents and vasodilatation and increased vascular permeability. There's also a theory that the virus may lead to endothelial dysfunction, leading to increased risk of thrombin formation and endothelial inflammation, leading to a DIC type of abnormality. The virus may also lead to dysregulation of the immune system directly by leading to reduced T cell levels, and the virus may directly interact with interferon, leading to increased amounts of cytokines, leading to a cytokine release syndrome or the cytokine storm. So there are various mechanisms by which the virus can lead to injury at a vascular level and therefore involve the myocardium and other organs. So in terms of COVID-19 and the heart, we see from publications that the heart is involved quite frequently in patients with COVID-19. Patients may present with inflammation of the heart muscle, known as myocarditis, or because of respiratory failure, patients may develop hypoxic cardiac injury, or because of the stress related to having an infection, patients may develop a stress-induced cardiomyopathy, which is reversible, but in the extreme form may present as a cardiogenic shock. Patients may also develop microvascular ischemia due to, as mentioned, vasculitis or endothelial inflammation with a DIC type picture. Patients may also have disease within the epicardial coronary system, such that they have increased propensity to plaque rupture, leading to acute coronary syndrome, such as ST elevation MI or non-ST elevation MI. And there may also be a supply and demand problem in patients with established coronary artery disease, where the patient may be so unwell with respiratory failure. The presence of coronary artery disease may increase the demand on their cardiac function, leading to increased myocardial oxygen demand, but there's a lack of delivery. This may lead to a type 2 myocardial injury or myocardial infarction. The right heart may also be involved due to cor pulmonale, as I mentioned, due to a massive PE or ARDS or severe pneumonia. And the cytokine storm may also lead to severe inflammatory response syndrome, which may also lead to myocardial dysfunction, again, which is reversible. Patients with pre-existing cardiovascular disease may have increased numbers of receptors, ACE2 receptors, and therefore may be more susceptible to infection directly from the virus. However, I think the mechanisms behind this is still unclear. So patients with COVID-19 may have a spectrum of cardiac presentation from being completely asymptomatic, only with abnormal investigations such as elevated biomarkers, troponin, NT-proBNP, or they may have abnormal ECGs and cardiac arrhythmia, but no symptoms at all, or may have just evidence of structural abnormality on cardiac imaging, again, without much in the way of symptoms. Or they may present, as mentioned, just with features of myocardial infarction, heart failure, or cardiogenic shock, or rhythm disturbances, or in some cases, sudden cardiac death. Again, these are quite rare. I'll go into a bit more detail on subsequent slides. Troponin rise and NT-proBNP rise is quite frequent in patients who are hospitalized with COVID-19. So troponin elevation may occur in 6.5% of patients, and about 13% have elevated NT-proBNP levels. These elevated levels of these biomarkers are associated with increased risk of death at 28 days in the hospitalized patients in adjusted models. The troponin rise is more of a reflection of myocardial injury. The NT-proBNP rise may be more of a reflection of cardiac dysfunction. The troponin elevation may occur because of myocarditis, or as previously in my previous slides discussed, stress-induced cardiomyopathy or myocardial infarction. In this meta-analysis of studies from last year, if there is evidence of troponin leak, these patients have an 8-fold increased risk of all-cause mortality. ECG abnormalities are also been reported in patients with COVID-19. So in a large study from New York in hospitalized patients, where 11.9% of these patients died over a 2 to 7 week period, abnormalities of the ECG were reported, ranging from atrial fibrillation to atrial flutter in about 5.6% of patients, to just repolarization changes, to right bundle branch block or atrial premature beats. These highlighted areas are significantly associated with mortality in that cohort of patients. So ECG abnormalities were reported in patients with COVID-19 who were hospitalized, and premature beats, right bundle branch block, localized T-wave inversion, non-specific repolarization changes, all have been associated with increased risk of death. Echo abnormalities have also been reported. Again, in a study from New York showed that 2/3 of patients who are hospitalized with COVID-19, which had evidence of myocardial injury, in essence, troponin rise, had abnormalities of cardiac structure and function, ranging from global left ventricular dysfunction, to regional wall motion abnormalities, to right heart involvement, to pericardial effusion, or to high filling pressures on echo. And the presence of these abnormalities and the troponin rise were associated significantly with increased risk of all-cause mortality in the hospitalized patients. In this survey from multiple countries, abnormalities of the echo, abnormalities of cardiac function were reported again in just about 1/3 of patients. Just about half of patients had abnormal echo features, of which 39% had mainly LV abnormalities and 33% had RV abnormalities. In patients who have pre-existing heart failure who develop COVID-19, they are at higher risk of death, or higher risk of being intubated, and higher risk of being admitted to intensive care. So having a diagnosis of heart failure in the pre-existing state and then developing COVID-19, the risk of ending up on intensive care or being intubated or dying is much higher than patients who don't have heart failure. In terms of new onset heart failure, interestingly, one would expect to find more heart failure, but in this New York study, 37 out of this is supposed to be 6,500 patients had new onset heart failure, and majority of these patients had pre-existing or risk factors for heart failure, such as ischemic heart disease or hypertensive heart disease. And some of these patients had new onset ARDS because of their COVID infection. The incidence of acute myocardial injury also seems to be playing a role in the new diagnosis of heart failure. In terms of patients presenting with cardiogenic shock and inflammatory syndrome, these patients who present with shock either have a myocarditis or inflammation, in essence, inflammation of the heart muscle, or a stress-induced cardiomyopathy. And we tend to treat these with inotropic agents or mechanical circulatory support. And these patients usually require time to recover from the myocarditis or the stress-induced cardiomyopathy. I have a couple of examples, and there are a few case reports. In terms of the cytokine storm, patients may present for multisystem inflammatory syndrome, which involves patients presenting with fever, GI symptoms, low blood pressure, poor LV function, and very high inflammatory markers. So in this patient here who was admitted just prior to Christmas, 30-year-old Indian software engineer presented with fever, rash, pneumonia, and had COVID-19 diagnosed, had multiple organ dysfunction with renal failure, liver dysfunction, and his echo here shows that he has poor LV and the right ventricle is very, very dilated and severely reduced. So there's severe biventricular dysfunction here. This is a view of the tricuspid valve, and the patient also has severe tricuspid regurgitation. The patient had a CTPA, which was excluded a pulmonary embolism. The BNP level was very high at 2000. The troponin, despite the LV dysfunction, was normal. This patient we treated with only inotropic agents alone, milrinone and some heart failure therapy. And within a matter of 4 or 5 days, his LV function recovered as seen in the right-hand panel here. So his LV has improved, the right side of the heart has reduced in size, and there's significant improvement in the RV function as well. This patient made a full recovery and went home, and we've been monitoring him as in outpatients. He's doing pretty well. This other case of a patient of Ghanaian origin who presented with features of shortness of breath, fever, multi-organ dysfunction. Again, a very high CRP of around 260. And this patient, in fact, had a very high troponin level and troponin above 2000 and a BNP just under 1000. His echo shows that he has a very poor LV systolic function. And you can just make out that there's this device which has been implanted. And this device is passing through the aortic valve, which is the impeller. And in this cartoon, the device involves a tube being put in through the femoral artery, passed up through the aorta and passing through the aortic valve retrospectively into the left ventricle. And this tube is then connected to a pump and essentially sucks blood from the left ventricle into the aorta and pushes blood into the aorta. And this patient had an impeller device combined with this VA ECMO device, which helps to maintain flow of blood to the various organs, ensuring that the heart is rested. So this combination of therapy allows the heart to be rested and the organs well perfused. So in essence, the combination of devices can increase the cardiac output by 5 to 7 liters per minute. So this allows time for the patient to recover from the infection. And in this, again, we had success in that the LV function recovered as we maintained the patient's organs, liver, renal function, and also the lungs. This patient went on subsequently to have a cardiovascular MRI scan, showing that the patient actually did have a true myocarditis where the heart muscle was inflamed, which explained the troponin rise of over 2000. It's interesting about regarding the mechanism of why myocarditis happens. So the idea of having direct viral infection of the myocardium via ACE2 receptors within the myocardium was postulated, but so far nothing has been proven so far. There are some case reports of myocardial biopsies taken demonstrating presence of coronavirus within the interstitium of the myocardium and also within macrophages which are circulated around the body and sometimes land within the myocardium as well, leading to a localized inflammation. So it's still unclear the mechanism behind myocarditis in patients with COVID-19, whether it's a direct viral involvement or whether it's an inflammatory associated problem. In this slide, I think you may have heard from the news that the attendance or hospitalization for patients with established heart failure, the frequency of hospital admissions during the pandemic came down compared to previous years, using the same months of the previous year. In the green line shows that the hospital admissions are much higher compared to the time of the pandemic. And the patients who were admitted during the pandemic who had heart failure had a higher rate of complications and lower survival rate. And the same thing has been observed for patients presenting with acute coronary syndromes. Acute coronary syndromes in this cohort of patients during the pandemic started to lower. So patients were presenting less frequently to hospital with myocardial infarction as the number of COVID cases increased. And compared to the year before, during the same months, there were much higher levels of presentation with acute myocardial infarction, and almost 40% drop in presentation with acute myocardial infarction. And this has been due to late presentation of patients because of avoidance behavior, trying to avoid catching COVID-19, or also probably reflecting changes in how hospitals were operating. I want to just finish in the last two slides to talk about long COVID. And so long COVID is something which is still trying to be defined. The closest definition is presence of long-lasting COVID symptoms over a 6 to 12 week period after an acute infection. And in this survey published by academics from UCL, where they performed a web-based survey of over 3,000 patients, majority of which were women, majority of patients do report fatigue. So two-thirds of patients, over two-thirds of patients, or three-quarters of patients present with fatigue as the main symptom, or post-exertional malaise in about just over a third of patients, and cognitive dysfunction in over half of patients. But all of these patients who have long COVID also have cardiac symptoms. And this is quite a noisy heat map. And there are at least 10 symptoms related to cardiac dysfunction that could be related to cardiac dysfunction, ranging from shortness of breath to chest pains to sinus tachycardia, palpitation, and also other symptoms. Interestingly, patients may have symptoms that may improve and then get worse over time. So there appears to be a relapsing and or recurring theme to these symptoms that patients may report. And often these patients who have long COVID continue to have disability, and a significant number of these patients aren't able to get back to work to a normal level. In this cohort from China of around just under 2,000 patients, at 6 months, the majority of patients presented with fatigue. That's about two-thirds of patients. A quarter of patients had difficulty sleeping. And interestingly, about half the patients had abnormalities on their chest CT scan, and half of patients still had abnormalities of gas transfer on lung function testing. And this was irrespective of having steroid treatment. So in summary, COVID-19 is associated with cardiovascular complications. There is a spectrum of presentation from being asymptomatic with abnormal investigations, ranging from troponin rise to abnormal cardiac structure and function on echo or MRI. And also patients may present with myocardial infarction, typically with type 2 myocardial infarction, where there's a established coronary artery disease, but there's a supply and demand problem. New heart failure is quite rare. Cardiogenic shock is also quite infrequent, but can occur and is usually reversible, and these patients require mechanical circulatory support. Conduction abnormalities are also frequently observed and associated with increased mortality, as are structural abnormalities in the context of raised troponin levels. So there is an association between increased mortality with cardiac involvement. Also, just to touch base again on long COVID, that it's relapsing, remitting, and patients often have cardiac symptoms. And the main symptom reported is fatigue and some feeling malaise with exercise. So I'll just stop at this moment. Thank you.
Thank you, Dr. Vazir. Over to you, Saeed.
Right. Hi, I guess it's my turn now. Hello, everybody, and welcome to this webinar. It's great to have you all on. Just starting to share my screen now. I'm going to. So I assume you can see my screen in the presentation. Yes. Okay.
Yes, we can.
So thank you for the introduction, Rory, and thank you for inviting me. And also thanks to Shaima for having me here. Ali has given the gist of all the details that we need to know about the background, the pathophysiology, the presentation of these patients, especially with cardiovascular background. So I'm going to have a short talk about the use of imaging in these patients, which is my area. So again, to reinforce the sort of problems we see in patients, obviously, we have the involvement of the lungs, so the pneumonitis, and in addition to that, the other major feature of this disease is thrombotic complications. But also we have the problems with the heart and the vessels, which are mainly a combination of plaque instability and myocardial injuries, myocarditis, and potentially a combination of all this in these patients. So just reminding you, we have an array of different imaging modalities that we can use in these patients. Some of them are more useful, and some of them are probably less practical rather than less helpful. So on the top, we have echocardiography, which is quite useful. It's obviously you can have it in bedside. It's non-invasive. But when it comes to more complex, more difficult diagnosis, we may have to use other modalities such as CT scan or MRI. The use of PET in these patients have been described, but in the acute setting, it's probably not a practical test to do, and we really need to know the findings in these patients. And when the patient comes with acute coronary syndrome, the patient may need an invasive angiography to deal with the problem at the time. So starting with thrombotic complications in these patients, it's actually quite a common problem in the acute setting. If we don't see it because we don't investigate it as much as we should do. So this is a series of patients that Myra, one of our fellows, reported, where we see a combination of thrombotic complications in multiple sites in the bodies of these patients, including obviously the thrombi in the pulmonary arteries, and also in the aorta, in the ventricles, and that leading to hemorrhage in these patients as well, or ischemic changes in the brain. So in this study that we published in autumn last year, we looked at the prevalence of thrombotic complications in the obviously most severe cases of patients who came to ICU. But it shows you the extent of the problem in these patients. So at Brompton, all the patients who came with COVID, whether they were with ECMO or without ECMO to the ITU, as routine we perform a CT scan on arrival. And as a result, we have systemic data from these patients. And in that, we noticed that 58% of the patients developed thrombotic complications. Just under half of the patients had pulmonary artery thrombosis. And interestingly, only a small number of patients comparatively had pulmonary venous thrombosis. And from those, many of the patients with pulmonary peripheral venous thrombosis didn't have the pulmonary embolism. So we hesitate to call them P as opposed to, so we call them pulmonary thrombosis rather than pulmonary embolism. And also in a smaller number of patients, we see systematic arterial thrombosis with end organ damage. And we have seen kidneys get damaged. We see pancreatitis when it was not expected. We see ischemic changes in the brain and so on and so forth. And the importance of this study, the important thing to know is that patients who had thrombotic complications were less likely to survive and be discharged as opposed to those who didn't have it. Right, coming to myocarditis, as was indicated before, it's a phenomenon that is seen in these patients and can bring the patient to you and us for further investigation, finding the cause. So in a series of 39 autopsy patients, you might have seen this study. It's very interesting, and all the results have been just eye-opening. About 61% of the patients had an evidence of viral genome in the myocardial tissue. So it seems that the virus enters the myocardial cells, and obviously some of those come to be to have clinical myocarditis as opposed to a subclinical myocarditis that may go undiagnosed. Like any other myocarditis, the majority of these patients present with non-ischemic pattern of enhancement and edema in the myocardium. Usually it's the posterolateral wall of the myocardium is involved. On MRI, we see enhancement of the myocardium in the epicardial surface of the heart, and with T2 weighted imaging, we can quantify, we can see edema in the myocardium. So this is a case of myocarditis, which is quite well presented, this patient. And there are times that the myocarditis can be diffuse. So this is a case that we had actually at Brompton, I think. And there was diffuse edema in the whole myocardium, but nothing as focal as was presented in the previous patient. Interestingly, when we looked at the MRI and the CT scan, we saw these lesions in the periphery of the lung. So these are cavitating lesions, which are ischemic. Basically, this patient had areas of ischemic damage. You may call it infarcted. I try to avoid that term, but ischemic changes in the lungs as a result of potentially thrombosis of the pulmonary vessels. So this is a case where a patient had acute coronary syndrome. So this was a 45-year-old man who presented with acute chest pain and had a STEMI at the time of the presentation with mild, actually only pulmonary involvement of COVID. So he was COVID positive. And we have seen during the COVID some of these patients presenting with actually florid COVID and acute coronary syndromes. These patients usually get coronary angiogram at the time. And so if you image these patients later on with delayed enhancement myocardial imaging on MRI, the pattern that you see is you see some enhancement of the myocardium, which is because of the entrapment of the gadolinium in the in the interstitial space in the myocardium, and then a dark ring in the center, which is basically the hemorrhage, the area of microvascular thrombosis. That is a sign of acute myocardial infarction in these patients. We know that the main patterns in these patients are either the inflammation, the myocarditis, or the myocardial infarction, but some patients may have a combination of these two. And anyway, we know that patients who have myocardial infarction, they have inflammation surrounding the area of ischemia as well. So one of the phenomenon that we see in these patients is what you call it long COVID or chronic COVID. So these are patients who had a history of COVID 3, 4, 5 months ago, and they are still symptomatic. And then they come and they get imaging. And we do actually quite a few number of these cases these days. And this is what you see. In this case, this patient presented with COVID in December 2020, and this CT scan is from, actually it's from today. I just picked it up from my list this morning. And the pattern that we see in these patients is that we still see some residual, what we call ground glass changes in the lungs, which is in the, they have what we call a perilobular pattern, as you can see here, around the lobes, and what you see in the center is the pulmonary lobe. So this is what is defined as organizing pneumonia in these patients. Some of these patients with organizing pneumonia respond to treatment, and then they recover, and in some of them, the lungs lead to interstitial lung disease. So if you see here, this airway is actually seems to be dilated and pulled apart by the changes in the interstitium. So there is some element of interstitial lung disease or pulmonary fibrosis is evolving in this patient. This is another example. On the right is a CT scan in another patient who had COVID, and this study was performed probably a couple of months after that. You can see that the airways are slightly irregular. They are dilated compared to the vessels which are running next to them. There is distortion of the parenchyma of the lung. That is typical of organizing pneumonia in these patients. So in the follow-up examination, we can see that a lot of those ground glass, those bright regions in the lungs have resolved. There is still some distortion of the parenchyma, but things are much better. So a lot of these patients may respond well to usually corticosteroids, and they improve. But as you can see, that not all of those changes have resolved, and this resolution is actually quite slow in some of these patients. So, so there has been some trials to present physicians with some diagnostic algorithms to help us choosing what test has to be done in these patients. I don't think there is a consensus, and what I'm presenting here is just one of them that is presented in one of the papers. What I would like to just emphasize is that the core imaging techniques that we use here, as you can see here, are the echocardiography, the invasive coronary angiogram, the cardiac MRI, and the CT scan. With CT scan, we have the opportunity to image more than one structure, as opposed to the echocardiography or the cardiac MRI to some extent, or even the invasive angiography. We can look at the same time at the pulmonary vessels, as well as the heart, the coronary arteries, the aorta, and also the lungs. So you can have a wide vision of what is going on in the chest, which is quite useful in these patients. Although it can be challenging in the acute settings when the patient comes to the hospital, because the heart rate is quite fast. So it's not always easy to image the coronary angiograms, but we have done few of those studies during the peak of the COVID because the patient is in ICU, the troponin is very high, patient cannot go to the CMR with all the equipments attached to the patient, and we need to make a diagnosis. So the patient comes for a CT scan, and we try to get as much information as possible in these cases. In the acute setting, is obviously it's very difficult to image these patients. So this picture that was published in the Telegraph is actually outside my my office. So each time I wanted to exit my office, I had to look outside to see if there is a traffic light, red traffic light or not. So you can see just carrying these patients around from the ICU, which is on the left side, and to the CT scan, which is on the right side, is quite difficult. It can be dangerous to the patient and also to the staff, but the information you get from that can be quite useful. But when it comes to outpatient, when patients are not that unwell, then the imaging these patients are much easier in the CT scanner or with MRI. However, we have to obviously look after the safety of our staff and also the patient in that setting. So in conclusion, imaging plays a very helpful role in the diagnosis of acute, but also long-standing pulmonary and cardiovascular COVID complications. And the main array of tests that we use in these patients include echo, CTCA with CTPA. We can also use another technique, which is dual energy CTPA, to look at perfusion in the lungs, and finally cardiac MRI. And thank you for listening to this lecture, and I will be very happy to answer any questions.
Thank you, Saeed. We've got a few questions. So I'm just going to read them out. If you or Ali decide which was more suitable to answer the question, I'll just start with the first one. In a young post-COVID patient, in bracket October 2020, with normal blood test, but presenting with shortness of breath alone, what investigations would you suggest?
Right, okay. Okay. You're muted. Yes, you.
So can you just repeat the question again, Shaima?
Sure. In a young post-COVID patient in bracket October 2020 with normal blood test, but presenting with shortness of breath alone, what investigations would you suggest?
Very good question. So I assume that the BNP troponins are within normal range. So, you know, I would probably assess that by doing I think a CT scan would probably be more informative in assessing the lungs further. But before that, probably a lung function test and an X-ray would probably be better to do in a young patient. And then an echocardiogram for any structural abnormalities of the heart. And depending on whether or not there's any family history of heart disease or any other risk factors, then one would consider doing other investigations. In terms of the CT scan to assess the lungs in further detail, is definitely much more sensitive in picking up abnormalities with the lung parenchyma compared to an X-ray. In Saeed, your area, what would you say in that scenario?
Yeah, I totally agree with you. The chest X-ray has a low sensitivity in these patients, even in patients with COVID. In a young patient, we take that into consideration and try to perform a low-dose scan. So with the modern CT scanners, like the one that we are using at UME Center, we can perform very low-dose CT scans to look at the lung parenchyma, if that is the question. The problem is that with the other modalities such as MRI, we won't be able to see the parenchyma well, because basically it's a simple physics cause, which is the air kills the signal from the in the MRI. So as a result, CT scan is the best test, but we try to perform it with the lowest dose possible.
Yeah, and I think another important point is to also consider cardiopulmonary exercise testing in this type of patient who's young, any abnormalities of the respiratory function as well as the cardiac function, which could come out with the cardiopulmonary exercise test.
Thank you. Next question, do you have any suggestions on how to manage new hypertension in post-COVID patients with neurological symptoms and marked autonomic dysfunction observing at present in neurology, but when would be the time to consider antihypertensive, normal echo, troponin, chest pain on standing more than 10 minutes associated with sinus tachy and post-extranotional malaise, sorry, I can't pronounce malaise, lightheadedness?
Yeah, so I think this question is a very good one. I think autonomic dysfunction, I think, is an interesting one because first of all, I mean, one has to confirm that there's autonomic dysfunction, which I assume has been. So, for example, doing a tilt table test on the patient, looking at what happens to the heart rate and blood pressure. So it sounds like the patient has on standing sinus tachycardia and some chest pain. So in these sort of scenarios and hypertension, so you know, I'd like to know what the relationship is with regards to sinus tachycardia and the blood pressure. So when the patient does develop a sinus tachycardia, do they drop their blood pressure? Is that why they've got a sinus tachycardia? And if so, could avoradine, which is that lowers the heart rate, only doesn't influence the blood pressure, be helpful? Is this some form of POTS syndrome type of presentation where sometimes avoradine can be helpful? I think these patients with COVID do report feeling dizzy, and especially with postural changes. And I think with time, it seems to get better from what I've experienced. So I think a period of observation, and if the cardiac tests are reassuring and normal, then that would be helpful. But in terms of the relationship between chest pain, sinus tachycardia, tilt table testing would be an important thing. And to what extent do they have an autonomic dysfunction? Is that also involving the GI system? Do they get bloated symptoms with delayed gastric emptying, or do they have any other abnormalities of the autonomic system? Yeah, and in those sort of scenarios, there are specialized units at Queen Square, for example, that focus on autonomic dysfunction or autonomic dysregulation, and they will probably do further investigations to try and understand why there is that, why there is autonomic dysfunction. Because trying to treat blood pressure in someone who has fluctuating blood pressure with antihypertensives classically leads to a scenario where the patient can feel even more dizzy. So, so I think getting the diagnosis correct is probably an important factor here. Yeah, what does the person asking the question think about that answer? Have they tried avoradine themselves, and have they proven?
Dr. Sarah Mason Whitfield. I don't know if she's able to let you know.
Yeah, I think in my typed out answer to her question, I also mentioned getting an MRI scan would also be helpful, just to ensure that there is no cardiac abnormality in terms of structure. I think that will be also to just to make sure there's no scarring of the heart muscle. That would be helpful in terms of the chest pain side of things.
Next question is from Dr. Ziva Bergman. Sorry if I'm pronouncing that wrong. She's the clinical lead of Long COVID Clinic in Southeast London, and she's seen a lot of intermittent chest pain. Is it possible to have delayed pericarditis with normal TROPS or BNP? And how useful is CKMM and CKMB?
Yeah, so I answered that question by typing an answer, but essentially I'll go just summarize that. So troponin is much more sensitive as a cardiac myocardial marker compared to CK. So troponin is like high sensitivity troponin in particular. If there is myocardial injury and high sensitive troponin is elevated, the CK may be normal. Now, if the troponin is normal, it's unlikely that the CK-NB is going to be abnormal. So troponin always trumps CK. In terms of cardiac pericarditis, I think it will be helpful to get a cardiac MRI, because if there is active pericarditis, you should be able to pick it up on an MRI scan. And if there is active pericarditis, typically the inflammatory markers should also be raised, like a raised CRP. Now, I've had a few patients who've had presentations with recurrent chest pain. I've done MRIs on them, and the MRI comes back as normal, or perhaps a history of previous myocarditis with recovery. And these patients keep coming back with chest pain. And often I just think a bit more laterally. For example, I'll do a D-dimer, and often this may be elevated. And if it's elevated, then I'll do CTPA. And I've been surprised on one occasion where D-dimer was mildly elevated, and the patient had a previous CT scan to exclude PE, and the PE was initially excluded, but on subsequent scanning, because of the slightly high D-dimer that I saw, the CTPA came back as positive for a pulmonary embolism. So the recurrent chest pain we thought was related to recurrent PEs, and this is something that I think one could expect in someone who's had COVID in the past.
Yeah, to echo what Ali said, I also had few patients where we did actually CTCA to investigate the cause of angina, and the patient had a normal coronary arteries, but positive P. But then when I called the physician, we found out that there was a history of previous COVID. And so that is always a possibility in these patients. And unfortunately, there is no exact rule how to find these patients with P post-COVID. And if you investigate everybody, then you may have a long number of patients who were negative, but then you would have also a number of patients who are positive.
Thank you, Saeed. We've got an answer back from Sarah regarding the addition. He said parasympathetic symptoms from head to toe, small pupils include increased saliva, no sweating, dry skin, etc., etc.
Yeah, so definite autonomic symptoms.
Okay. We've got another question. Can you use ultrasound to assess the lungs?
Yeah, over to you, Saeed.
Yes, so ultrasound, the sound doesn't go through the air, and as a result, if the lungs are aerated, the only thing you see is the shadow. However, in the acute stage of very severely diseased patients, when a significant part of the lung is consolidating, so there is fluid in the lungs, then you can use the ultrasound. So in the ICU, in the ITU, we use ultrasound to look at the lungs. But for outpatients, patients who may have COVID and may have a cough, ultrasound is really not helpful. The other time that ultrasound can be helpful is to look for pleural effusions, obviously, and pericardial effusions. But to look at the lungs, unfortunately, ultrasound is not useful modality of imaging.
Thank you, Saeed. Next question from Tony. I work as an occupational medicine with fire service. We have about 100 operational firefighters off work with long COVID, most ages 30 to 50 years, none hospitalized, but all around 4 to 6 months post-acute infection. All were super fit triathletes, etc. Now they are struggling with daily, not just fatigue, but breathlessness. If they try to exercise, GPs have sent them for chest x-rays, told normal, but nothing more been done. I feel frustrated, none of them have improved. Should we wait for them to improve, or how do they move on basically?
Ali, are you going to answer that question, or shall I take
so
it?
I saw that question on the Q&A. My feeling is that if you have a cohort of people who are still complaining of symptoms, I think they should be investigated more closely. And I would run, I wouldn't just rely on an X-ray, say the lungs are okay, just get on with it. I think these patients need investigation and rehabilitation. I mean, we have at the Royal Brompton, we have a rehab. Well, we have research studies which involve having a rehab. These are patients who are being looked after by respiratory physicians who have chest physio. And one of the things which I reported in one of the slides was there is abnormal gas exchange in these patients up to 6 months after COVID, and whether that's contributing to their breathlessness, plus having abnormal CT scan 6 months after, whether that's also, I mean, I've got a few of my own patients who developed COVID-19 and still very symptomatic. So, on having their CT scans of their chest, they still have persistent abnormality within the lung. And their lung function is still abnormal, and their breathing pattern is also abnormal as per the respiratory physiotherapists. So I think this is something which is not going to get better overnight. They do need rehabilitation and further investigations. And I think probably the quickest way to get assessments is to participate in research trials which have a focus on rehabilitation and investigation of breathlessness. And there are these studies available, for example, at the Royal Brompton, and maybe that may be a method of getting these guys assessed. But I think if patients are symptomatic, irrespective of how fit they were before, they should be assessed in greater detail, because this is clearly a condition that we're still learning a lot about, and we need to gather more information and err on the side of more investigations to understand what kind of pathophysiological complications we're dealing with, and what kind of supportive treatment we can give, again in a more of a research dimension as opposed to established treatment.
Thank you. With regards to imaging of PE in long COVID, it's, for example, due to shortness of breath or chest pain, would a negative D dimer avoid over-imaging?
So in my own practice, I would, if the patient still has symptoms, I'd be more reassured by performing an imaging investigation. So I would discuss it with my radiological colleagues about which investigation to consider. Doing an echocardiogram would also be quite helpful to look at the right side of the heart, and doing an exercise echocardiogram may also be helpful, especially if the pressure on the right side goes up during exercise, which could be a manifestation of chronic thromboembolic disease of the lung, for example. So I think investigating would be the way forward.
What I've noticed is that if the D-dimer is completely negative, it's very within the normal range. That's very reassuring. But in a number of these patients, we see the D-dimer that has raised, but not to very high levels. And in those patients, it's really difficult to know if they had thrombosis or not. And just reminding you that in a significant number of these patients, they only have an end vessel thrombosis in the lungs, not a large blob in the proximal arteries. And that can be basically the cause of shortness of breath in these patients. And it's important to make a diagnosis of that, because you can at least attempt to treat it with anticoagulation. And we can't give anticoagulation to a patient who doesn't have a diagnosis.
Thank you. Dr. Sarah Mason Whitfield's asking, I have a patient with post-COVID syndrome for 12 months with normal CTPA but abnormal gas transfer. VQ scan showed likely PE. Are you seeing much of this in your practice?
I don't see it a lot in my own practice, but I have been surprised by patients who present atypically and end up with a diagnosis of a PE. So I find that PE can manifest in many different ways. Yeah, I think it's yeah. So I have a patient with post-COVID syndrome for.
Yes, I definitely observe that when we do imaging for these patients from the
Yes. So
lung COVID.
the VQ scan actually looks at a different area of the lung in terms of PE. Is that correct, Saeed? So the CTPA would be pretty good at looking at the more proximal arterial system of the pulmonary vasculature. And often we actually do CTPA. If we don't find anything, but our suspicion is quite high, we also do a VQ scan to look for a more peripheral type of abnormalities, which may be picked up and not picked up on a CT. This is from my own understanding of imaging around it. Is that your understanding too? Is that what you?
Yeah. So with a VQ scan, with the Q part of that, you give tracers that go, and these are very small particles that go into the end of the vessels, to the vascular bed at the end. So if the vessel is occluded at some stage, that tracer cannot get to the end of the vessel, and as a result, when you image this patient, those areas will be tracer-penic, so it look dark compared to the rest of the lungs. So you can look at the end vessel obstruction. On CTPA, a standard CTPA, you can follow the arteries to the subsegmental level, but not after that. To look at the vascular bed, basically the perfusion, if the proximal vessels look normal, you need to use other techniques such as CT perfusion or dual energy imaging, where you look at the maps of the iodine in the lungs.
Great.
Thank you. We've got a couple more questions. I don't know if it's easier for Ali to type the answers as we've run out of time now.
Okay. Yeah, I can do that.
Thank you all for joining. This webinar is recorded, and we will be emailing the recording out to everybody, and certificates will be going out early next week to everyone that's attended. And thank you so much for your time. Thanks to our speakers as well.
Thank you.
Thank you. Bye to everybody.
Bye-bye.